Hi everyone, my name is Jeffrey Callahan and this is my presentation on the health belief model. So to start the presentation, I'm going to give you a little bit of a background on the health belief model, including its history and its application throughout time, the constructs of the theory, which include the primary and secondary constructs, and I wanted to give you an example of an infographic that can be used to explain the model, which is to the right on the screen. So, to begin, the history of the health belief model. During the 1950s and 1960s, the U.S. public health services were mostly focused on the prevention of diseases, and they left the treatment of the diseases to the local hospital systems for individuals. They were having a little bit of a difficult time in getting individuals to show up for early detection screenings for things like tuberculosis, cervical cancer, dental disease, and rheumatic fever. In order to make people care about these diseases that they weren't necessarily currently suffering from, but could suffer from in the future if they weren't able to detect it early enough and the progression of the disease took its course, that is how the basis of the health belief model was founded. During the discovery process for the campaign that they were working on to get people to get these early detection screenings, fear was found to be a great motivator. And the first time that the health belief model was used was during the 1950s in a campaign to get people out for early detection of tuberculosis screenings through x-rays. And even though it's not a US campaign, you can see an example of one of these types of campaigns on the right, which was used in the UK at the same time. Some of the constructs of the health belief model are shown on the right, and I will explain these here. So, again, as mentioned before, the health belief model is a fear based health behavior theory, meaning that if the model works and the individual adopts some kind of health behavior, it was based on their beliefs that are shown in the individual beliefs box in the middle of the picture on the right. The four main constructs, which are these individual beliefs, are perceived susceptibility, perceived severity, perceived benefits, and the perceived barriers that are keeping an individual from partaking in the particular health behavior that is being presented in the campaign. It used to encompass self efficacy, but it was later added as a separate individual belief in 1988 and became the extended health belief model. However, we will be focusing on the original health belief model in this presentation. They're, unlike most um, theoretical models, this does not have a primary or secondary structure. So, in most models, you'll see a parallel, a serial, or a moderated construct model. However, in this model, it is unclear if, like in a parallel model, all of the constructs work together at the same time, or in a serial model, they would work in a sequential order, or in a moderated construct, they would work through a moderated version of the campaign and have the focus directed at certain points to certain constructs. However, as I said, this model, the health belief model, does not have a set structure, and there have been studies like the ones that are listed in the bottom right that investigated this and were not able to find conclusive evidence that it is one of these models. So, to break down the four main constructs in a more robust way, perceived susceptibility is the risk an individual sees for themselves of contracting an illness or disease. Perceived severity is the seriousness of contracting an illness or disease an individual deduces for themselves. The perceived benefits are the beliefs an individual has on the effectiveness of actions presented to them to reduce the risk of disease or illness in a campaign. And the perceived barriers are the beliefs that an individual has on the negative aspects of a situation, keeping them from partaking in a health action. The application of the health belief model. It's a theory of health behavior, which again means that there is a health behavior that can either be adopted or rejected based on how effective the campaign for this health behavior is. And it's particular to each individual based on those individual beliefs that we discussed previously. This also means that it's a psychological expectancy value model, which means that an individual has to weigh the pros and cons of what is being presented to them to be able to either adopt or reject the health behavior. The desire to avoid illness or get well and reduce illness through a specific and defined action is the underlying part of the health belief model that makes it different from other value expectancy models. And then it also depends on fear and message framing. So the fear, again, is the overarching concept that holds together the health belief model, whereas the message framing can either be gain frame or loss frame messaging, meaning gain frame as in do this action in order to save your life, or loss frame, which is if you do not do this action, your life will be lost. Those are the two types of message framing devices that you can use in the health belief model, and it depends on the situation and the individuals in the population that you're trying to target for whatever campaign you're performing. So to look at the effectiveness of the health belief model, we can look at two different case studies. One is the unused opioid disposal campaign that took place in rural Appalachia at an upper extremity and peripheral nerve surgery clinic, where 170 of the 334 post-surgery opioid prescription eligible patients received informative pamphlets, and the other individuals did not. So there was a control group and an experimental group. The pamphlet receivers were the experimental group, and the non-receivers were the control group. This is a quantitative study to measure the percentage increase in drop box opioid disposal rates after patients received the informative pamphlets. And then both groups were interviewed before and afterwards to get a gauge on what percentage of these individuals actually use the prescription drop box for unused opioids after their surgery. There was a 100% increase in the individuals who actually used the drop boxes after surgery that were in the experimental group when compared to the control group. So it went from 11% in the control to 22% in the experimental. The pamphlets mostly focused on national statistics for opioid misuse and overdose rates that were provided by the CDC and the NIH, which were used to increase perceived susceptibility and severity to opioid misuse if there were unused opioids lying around their houses. The pamphlets also gave the location of the nearest drop boxes and instructions on how to use them to eliminate perceived barriers such as self-efficacy or lack thereof. So some of the pros and cons of this particular study seemed that the study seemed to increase perceived threat or perceived susceptibility and perceived severity to individuals in the experimental group, and it eliminated perceived barriers or lack of self-efficacy to utilize drop boxes. Some of the cons, however, were that the sample could have been larger and from separate locations rather than just the one, which could lead to some potential bias in the results. And data presented is more generalized in the pamphlets rather than specific to the location of Appalachia, which actually is one of the hotbeds of opioid misuse in the country and could have been utilized more effectively. It did not account for past use of drop boxes, and it didn't account for family history of addiction, which could have influenced the decisions of individuals to either use or not use those drop boxes. To fill in the gaps that were shown here, the social cognitive theory could have been used, which utilizes the triadic reciprocal determinism. So it shows that interpersonal, environmental, and behavioral actions all work together to influence an individual's decision. So in this case, interpersonal could have been the interactions with others using drop boxes or misusing opioids, which could both be equally determinant in whether or not an individual would keep or dispose of opioids. The environmental impact, which could be that an individual is living in a heavy opioid misuse area or an area where opioid dealers are in an individual's area that they could give their opioids, or that they have already been misusing opioids because of this fact. Behavioral could be past use of drop boxes or past misuse of opioids. Again, kind of like the interpersonal. However, it's a little bit different because it's completely personal and the behavioral. And then finally, it gives an idea of why individuals may utilize drop boxes or not in each group, besides fear of misuse in the pamphlets that were presented to them. So the second case study is an increasing knowledge of pap smear testing in women. There were 2 clinics used in Iran. The patients of these clinics were part of the experiment, and it was a quasi-experimental study on 70 women where half were given a 45 to 60-minute health belief model based educational session on pap smears, their effectiveness, and the importance in early detection. There were 35 in the control group with no sessions given. There were 35 in the experimental group with sessions. Then there were questionnaires used before and after these sessions to gauge their knowledge and their scores in the 4 constructs of the health belief model. So the results were that the mean scores of knowledge on pap smear importance and effectiveness was significantly higher in the experimental group after the sessions were given than the control group. The mean scores of perceived susceptibility, perceived severity, perceived benefits, and perceived barriers were also statistically much higher in the experimental group than the control group after the sessions. And before the sessions, there was no statistical difference in these 2 groups. So it shows that this was very effective in increasing the knowledge of these women, as well as increasing the 4 main constructs of the health belief model. Some of the pros of this study were that educational sessions increased the scores of all constructs again, and the means it means that there would be likely fewer missed appointments of pap smears in the future for this group. Some of the cons were that there was a small sample size and selection bias could have taken place because there was only 2 clinics used, and we don't really know the demographics and backgrounds of these women in the area of the clinics. There was also no accounting for previous knowledge of pap smears. There was no accounting for societal beliefs and personal attitudes towards pap smears either, which is why the theory of planned behavior could be used to fill in the gaps that were missed in this particular case study. So the theory of planned behavior focuses on attitudes towards the behavior, subjective norms of the culture, and the perceived behavioral control. So the attitudes toward the behavior, by adopting the behavior, what is gained or lost in the eyes of the individual? That's one of the questions that could be answered. The subjective norms is what are the things that are deemed as normal in that culture, which in this case, Iran is a very heavy Islamic country that sticks to strict religious views, and women getting pap smears may be viewed differently here in Iran than it would be in the United States or other Western cultures, and we don't know how the women feel, going into those appointments. And then finally, the perceived behavioral control is essentially your self-efficacy and how much control do you believe you have over the situation that is being presented to you. So how much control do these Iranian women feel they have in getting their pap smears yearly, and how much of a control does that play into them actually getting the pap smears? So some of the limitations, and this is the final slide of this presentation of the health belief model, is it doesn't take into account societal or environmental beliefs towards the action that's being presented. So some of the questions left are, how do these beliefs affect the individual's attitudes and beliefs towards the health action, the societal beliefs, that is? How will partaking in the action affect their societal standing? What are the social norms in that society? And then another limitation is there's no accounting for previous health actions related to one in the campaign, which goes back to especially the prescription opioid. There was no accounting for whether or not the individual had misused opioids or not, or if they used the prescription drop boxes. Another limitation is that it assumes that individuals all have the same access to information, and it assumes that all individuals are capable of interpreting the campaign in the same way, and that's just not the case for most of these. I hope that you've learned something about the health belief model, and I hope that this presentation was effective and engaging, and I hope you guys enjoy your night. Thank you.